Try to come to a quiet place. The next speaker is an old friend of mine, Pam Floener. She has a German last name. I don't know actually how you say that thing in English, but in German it's Floener. Frau Floener. Volume up. I can't do anything about the volume. It's back there. Pam worked, when I met her many years back, with Jerry Hirsch, who is one of the main researchers on the detoxing effects of methionine, and who did some beautiful work on using methionine for detox, and actually led me onto. Pam was wondering why I stopped using a Redoxal, which was the product, and it was only because I discovered there is similar equivalent amounts of methionine in sauerkraut, and so I started putting many of my patients, including myself, on high doses of sauerkraut, which has the additional effect of having a high amount of fiber and vitamin C and other things in it, so it comes in a perfect package. Pam since then has become the main representative of the Heil company. Heil is the company in Germany that has collected the most research on the use of DMPS. And Pam has worked closely together with IAOMT. Many of you are members of that group here, the International Academy of Oral Medicine and Toxicology, which many people always ask me, what's the difference between biological dentistry and IAOMT? Shouldn't we do this group or that group? Well, IAOMT is a wonderful group in terms of condensing what has been generally accepted in medicine. It's a group that plays it very safe, and therefore from our perspective is very conservative. And sometimes conservative means, when you want to stay conservative, that your 6-year-old child that you're treating is actually going to die. And so biological dentistry has had the courage to say, well, we're going to stay conservative as long as we can, but sometimes we have to move out from the safe boundaries of things and do other things. And so that's the relationship a little bit. IOMT condenses the knowledge that's out there in a beautiful way, supports research in a beautiful way, and biological dentistry is a bunch of quacks and wild people like us, and there is a relationship between chaos and order in the world, that all order emerges always out of chaos. And so biological dentistry represents the chaos, and IAOMT represents the order, and there is a relationship between the two. Pam has had the beautiful task in the last few years to introduce many of us to the use of oral DMPS, which this morning you've heard is an extremely effective compound in heavy metal detox. In fact, with all the statistics that I know, it is the most effective compound of getting metals out of the system in the right way, by giving it in the right pharmacokinetic way, giving it every 8 hours or so. And Pam is introducing us now to whatever her latest thing is. You're on.
Thank you. Thank you for that introduction, Dr. Klinghardt. I am also a physician's technician, a registered medical assistant. I'm certified in nutritional counseling, and I'm a chelation technician. I have 30 years in the healthcare field, both traditional and alternative, both medical and dental. So I kind of have 2 feet on both sides at all times, and it's an interesting place to be in. Today I want to talk to you about DMPS, but I also want to cover something else that I get a lot of questions on from physicians and dentists, and that is using an informed consent. So you should have, when you came in, received a little stapled together pages with a blue cover. This is DMPS on the front, and then another single sheet, white sheet, that says Guide for Informed Consent for Experimental Drugs. Does everybody have those 2 things? If not, raise your hand and someone will bring you one. I'm going to talk about the DMPS first, and rather than give you a lot of the science, which you can get all the references, all the scientific studies and everything that's been done on DMPS, you can get that from our scientific monograph, which if you would like a copy of it, I do have it on computer desk in PDF format if you will stop by our table, and they are free of charge, and I'll be happy to give you one. It's 188 pages of all the data up until 1997 on DMPS. Now, one of the first things I want you to do, when I was on the airplane flying out here from Atlanta, and it was a late flight, I was reading through my handout, which I had just printed up a new batch of them, and I was horrified to find this major error, a word that got dropped off at the margin. So I want you all to go to page 9 in your little DMPS handout. And where it says routes of administration, page 9, where it says routes of administration, drop down to where you see the big bold capital letter type where it says do not mix injectable with other solutions. And then right behind that it says do administer by the drip method. That should say do not administer by the drip method. The word not got dropped off on the margin when it printed. So I want, yes, it's small but quite significant. So please put those 3 little letters in there. Do not administer by the drip method. I didn't find any other major snafus in there, so I'm just curious to know how many of you here are physicians and how many are dentists? Physicians, raise your hand. Okay. Okay. And I assume the rest are dentists? And if you're other than a physician or a dentist, raise your hand. Okay. Just like to know what mix I have with the audience. Thank you. DMPS. DMPS deserved a very bad reputation, or earned a very bad reputation that it doesn't really deserve over the last few years, because there are a lot of misconceptions about DMPS, what it does and what it doesn't do. So, and these are most of the questions that I get via the telephone and the internet. We do have a website and people can email questions to me. One of the first things is people say, oh, don't use DMPS. If you have amalgams, it'll dissolve your amalgams. There has never been one case of amalgams being dissolved with DMPS. There's not one case on record. I'm not saying it maybe hasn't happened, but it's never been reported to us in an official way. In Germany, where they've used this drug for many, many years, and Heil has been making it since the 1950s, every year over there, their government agency that oversees drugs, which is equivalent to our FDA, gives a report to the drug company once a year on any reports that they have received from physicians or patients on any adverse reactions or problems with any of the drugs that they make. The drug company is then required to follow up and do an investigation on that. So with all the years of use, there's not been that problem reported. In fact, Heil has not had a report or a complaint from their German authorities for quite a number of years. Here in the States, it doesn't work quite that way. The FDA gets a complaint, they walk in and jerk everything off the shelf and shut everybody down. But in Germany, the requirement is much different. They also have very stringent requirements over there for getting drug approval. In Germany, DMPS is sold under the brand name of Dimaval. So when you see that in publications, then that researcher has used our actual finished drug product that's made in Germany in ampule form for the injectable, and it's called Heil DMPS for the capsules. Here, DMPS is legal to use. It's sold as a bulk chemical to compounding pharmacists who can then transform it into whatever delivery method the doctor has ordered, be it capsule or injectable. Most physicians are using injectable. But I would like to have you understand, and if you don't remember anything else today, oral is the preferred route of administration for DMPS. IV is used only in acute poisoning situations when the patient cannot take an oral medication, like when they're unconscious, or they have some severe gastrointestinal problem that where their absorption has been impaired, or they've drank something caustic as part of the self-poisoning attempted suicide where they cannot put anything down into the stomach, or if there's been a gastric resection or some kind of surgery where you've reduced the absorptive surface of the intestinal tract. So typically it's not given by injection in Germany. It's mostly always used as an oral preparation. About 50% of oral DMPS is absorbed. The other 50% stays in the intestinal tract. It binds the metals that are there and prevents them from being absorbed and being recirculated back through the body and coming back through the liver and out into the bile. So it's still doing something because, oh, you only absorb 50%, how good can that be? Well, it is doing its work in the intestinal tract. And you want to keep those metals from being reabsorbed and recirculated from the bowel and back through the whole system. So to prevent that from happening does help the patient. It gets excreted with the bile or with the feces out of the body. So you're continually trapping the metals that are in the intestinal tract and bringing it out with the feces without it going up and being recirculated through the body. And so you're also spreading your surface area for excretion via the kidney and the intestinal tract, versus most of what you give by IV comes through the kidney. Some does come out into the bile, but most of it goes through the kidney. So you're alleviating some stress for the kidney when you give DMPS orally. Dosing. As far as dosing with oral DMPS, Heil does not have a protocol for DMPS in chronic poisoning situations. The reason why they don't put out a protocol is because there are too many variables among the patients. Every patient is very individual. Everyone needs to be worked up and treated on their own individual merit as to all their secondary problems, other kinds of things that are going on with them, if they're really fragile patients or if they're pretty strong. For somebody that's very functional and goes to work every day, and they are just concerned, they'd like to see if they've got some metals coming out, and you give them some DMPS or a DMSA, and they won't have any problem with it. They can usually tolerate higher doses and more frequently. For these very fragile patients, they can't tolerate that, so you can adjust the dosage. So this is the art of medicine. DMPS is very flexible in terms of how you can administer it, in what doses, and how, as far even with challenge testing versus treatment doses. In the literature and in this handout that I've given you, there are the more common dosages used in challenge and treatment. But as Paul Cutler or Andrew Cutler stated earlier, it's not how much metal you can get out of them, it's not how fast you can get it out of them. That is a very dangerous course to take. Go slowly, go sanely. People want to get well fast, but you can't mobilize a lot of metal at any one time and get it excreted without making most people very, very sick, particularly your fragile patients. So I want you to keep that in mind, that oral DMPS, if you're going to use DMPS, and go slowly. Don't be in a rush to detox these people too quickly. Some people cannot tolerate chelating agents. Not everyone will benefit from DMPS or any other chelator. So what do you do for those people? Then you look to your nutritional support, your biological support the natural biological systems. Some people don't want to take chelating drugs, and that's fine. So there are a lot of options for them. But if you're going to use DMPS, please use it safely. Please read through our scientific literature. Please call me if you have any questions about how to use it with particular patients, and I will help you as much as I can. We also have a website. A lot of questions are answered there. The website's www.dmps.cc. not .com, just .cc. .cc is a new designator, so it's just .cc. Now, if you want to find out what happens when DMPS is used irresponsibly, either by the doctor or the patient, go look at dmpsbackfire.com. You know, this is a drug. If not used properly, there will be problems. But when it's used properly and the doctor understands the drug, and this is true with any medication, then DMPS works very well, and it's helped a lot of people. And unfortunately, those people that it has helped do not have a voice on the internet. No one has a site that's pro-DMPS. So you don't get to hear the wonderful stories that I hear from physicians and patients and how DMPS really helped them. Don't be afraid of it. DMPS and DMSA are very similar structurally, as you could see from what Dr. Cutler had up on his slide. Both of these drugs are analogs of BAL, British Anti-Lewis site, which no longer is available for use in Europe. I'm not even sure you can still get it in the United States. But it did have a lot of problems. It was by deep muscle injection only. It was extremely painful medication to use, and it did redistribute metal to the brain. So while it would cross the blood-brain barrier, it could carry metal in as well as carry it out. So we always have to consider that. DMPS does not carry metal into the brain. It will not redistribute metal into the brain. There are a couple of reports in the literature indicating that DMSA has the ability to do that, to carry methyl mercury into the brain and leave it there. And I've not seen any good studies showing that it would go in, take mercury out of the brain. DMPS will remove metals from the nervous system and from the brain if you use it long enough. Okay, there is some data out just published in 2001 on that by Dr. James Woods at the University of Washington. He's now with the Battelle Neurological Research Center. There are several researchers out there still looking at DMPS. Vaskin Aposhian, he's probably been looking at it the longest, and he also looks at DMSA. He's got lots of publications out on both of these drugs. Dr. James Woods, who identified a particular porphyrin peak that's present when mercury is coming out in the urine. If there's even small amounts of mercury, a specific peak, coporphyrin peak, will show up in the urine. So these are some other things. You know, everybody is always looking for tests, and what am I going to do? You know, what tests should I do? What numbers say the patient is toxic? There are a lot of tests. They all mean something, and they all mean nothing. I've worked in laboratory for 16 years, and I can tell you there are a lot of times you can look at a lab test, you can take that report and throw it away. Metal poisoning is not based on numbers. The diagnosis is not based on the numbers that you get on a piece of paper. Mercury poisoning in particular, it doesn't matter how much mercury is coming out of this patient or how much is in the hair or what you see in the blood, which is rarely that you see it in the blood, or how much is coming out in the urine. Whether it's a baseline test or a challenge test, the number is actually irrelevant if that's the only thing you're looking at. You must look at all of the available data. You must, and that includes a history of exposure, history or histories of exposure, occupational exposure. A lot of people are occupationally exposed and never realized it if they weren't working directly in a battery plant or a fluorescent lighting plant or something like that, but they did have some occupational exposure. So you want to look historically for exposures. You want to look for current symptoms. And almost every symptom that we know has been attributed to mercury. So that's not always real reliable. But also, you know, and of course, the amalgam issue. If they've had root canals, because the gutta-percha material can have some mercury in it. So you want to look at all of those factors, the history, plus your lab test, plus your symptoms, and then arrive at a conclusion. If you are doing testing and looking at the numbers, which there's nothing wrong with that, that's the way you document your diagnosis. Laboratory tests are to be used to document what you already believe or what you suspect and to help you rule out a particular diagnosis. So if you are going to look at the numbers, please do baseline testing first and then do your challenge testing. Look at your numbers before and after. And I realize that that gets expensive, that it's a financial burden for the patient, but if you're getting low numbers, you need the baseline to show you that you've had some increase. Seeing an increase in urine helps you to know that you've got metal stored in the tissue. What if you do a challenge test and your mercury level comes out at 5? You've proven nothing. At 5, nobody's going to consider that person to have a problem. But for that one individual, it might be a problem. If the baseline was non-detectable, if your baseline result was they could not detect any mercury in the urine, and then you get a 5, what is that saying? Somewhere they're storing some metals. So that's one reason why baseline testing is so important and what it tells you, the practitioner. The patient trusts that you know what you're doing and that you're going to help them get well. You can't help them get well if you only have critical, the post results. You need the baseline. You need to assess where that patient is on any given day, and that's why you pick a day and you do your baseline test. So whether it's DMPS or DMSA that you're going to use as a challenge agent, which EDTA is actually contraindicated in 3 places in the literature for mercury, then if you're going to use, please do your baseline testing first. That is one of the main messages I wanted to get, because I talk to doctors all the time who end up with either real marginal numbers or extremely high numbers. If you get a really high number, maybe that person was already excreting metal on their own anyway, and they don't need a chelating drug. How do you know when a person needs a chelator? It's the baseline, the values between baseline and challenge testing that help you determine that. It's the art of medicine. It's designing a treatment program for each individual patient.
I don't mean to interrupt, but being a dentist, I normally don't do baseline testing. So if you could please tell us, you say start with a baseline test.
Mm-hmm.
What is a test? Where do you get it analyzed? And approximately, so we have an idea what it costs, so we know what to pass on to the patient. And then is this covered by any kind of insurances?
Okay, well that's about 5 questions in one. Let me take it one at a time. First of all, if you are a dentist, I would find a good physician to work with and let the physician deal with the testing and the treatment and the administration of chelating drugs, because that is really, unless you have an unusual state where your license includes that in your scope of practice, doing chelation therapy is outside your scope of practice. That makes you liable, it makes you vulnerable. Also, most dentist offices aren't equipped to handle, doing 24-hour urine collections or even 12-hour, or any kind of urine collection or any kind of collecting of biological samples for that purpose, and then also the interpretation. So it's really better to work with a physician that can handle all of that, because you've got to look at a lot of factors, not just how much mercury is coming out or shows up in any kind of a test, whether it be urine, blood, or hair. Which, by the way, high hair levels of mercury are usually seen in fish eaters. This is methyl mercury that's in hair. The type of mercury and the vapor that comes from the amalgam does not show up in the hair. It will show up in the urine, but not in the hair. So when you see high hair mercury levels, you're looking usually at a fish eater or somebody who has a lot of gut bacteria who is methylating their own mercury. Now that can happen as well. So there was just a study that came out, and I read it so quickly I can't even give you the site, but if you contact me, I can give you what paper it was that came out on the fact that they looked at hair mercury levels, and in the people that were very high, they were fish eaters. They had them eat no fish for 3 months, and after 3 months they retested their hair, and the mercury levels had come way down, which just shows you that it's only the methyl mercury is going to be in the hair. And this is what the toxicologists go by as well. They rarely ever look at hair unless they specifically suspect methyl mercury poisoning. They're looking at blood or urine. And that's typically what you want to stick with, because to have a fish eater have a high hair mercury and you start chelating them, that would be really indefensible for physicians to do, because all you have to do is have them stop eating the fish. All fish now are contaminated with some level of mercury, unfortunately. And there again is another political issue. The EPA comes out and makes reports, the fish industry lashes back, but each state gives a fish eating advisory. Usually the Department of Natural Resources, or the equivalent in your state, will put out a fish eating advisory as to what fish are safe to eat from what lakes, rivers, streams, and how many of those fish you can have on a monthly basis. And in Georgia, where I'm from, they just recently put a warning in there, a big warning, to premenopausal women and children and pregnant women. So I guess you guys, it's okay. You can, have all the mercury you want, but yes. Yes.
Like in Arizona, they a few years ago said that thousands of women, pregnant women and children, risk mercury toxicity due to contaminated rivers and lakes in northern Arizona. But we have 5 coal-fire burning utility plants up there. And I know in the Midwest, they've had it on the internet, shows also that the mercury, it goes up in the air, water brings it down, it goes to rivers, streams, the planet, pick it up, small fish eat the planet, bigger fish eat the smaller fish, so there's, but I also understand that mercury in fish is not found so much in the cold water fish. Is that correct or not?
Well, I think that's what the fish industry would like you to believe, but they're finding it in all of them, all the fish. In fact, in Canada, last year, they were testing a lake where their loons live. That's their national bird. And this lake is in the middle of nowhere. There's no industry, and there's no anything around this lake. And they were testing the birds and the water and the various things because the loons have stopped reproducing. And what they found were high levels of mercury in the water. So high and so unbelievable that they actually thought the laboratory, or the people who had collected the water samples, had made an error, and went back and recollected all new samples, reran all of their tests, and actually tested some of the birds, and in fact those mercury levels were accurate. And so they're not sure where this is coming from. Well, it could be coming from hundreds of miles away, because mercury will go up into the atmosphere and it will travel for hundreds of miles, and you don't know where it's going to come down. When the Minamata Bay disaster happened, everybody heard about Minamata Bay and how bad the mercury poisoning was from the industry that was putting all this mercury up into the atmosphere, and it was coming down into the lake and poisoning the fish, and the local people were eating the fish. What you didn't hear about was another town 300 miles away where they had just as many cases of mercury poisoning from fish eating because of the mercury that traveled through the atmosphere. Came down and poisoned all those people, but they didn't get any attention. So mercury can travel hundreds of miles. Even after our trade towers went down, within 3 days, they were detecting higher mercury levels as far south as Florida in just 3 days.
Did you see the Wall Street Journal article just down a few days ago on mercury in children? Just on the, tell me about this very same thing. Tell me about the problems that we have with mercury in children. Very, very big issue.
Yeah, yes, it is, and it's interesting. Even the people that worked at the disaster site at the trade tower, cleaning up the mess, they tested some of them and they had high mercury levels, and they were developing a cough, and they're quite sick, these cleanup crews. And so they reported that in the news, and about these high mercury levels in their blood. Now that's serious. When you find high mercury in the blood, you're looking probably at an acute poisoning. And then they came back and said, oh no, we did the wrong test. These people really don't have mercury poisoning. They have the right, because you're looking at hundreds of people 30, 50, 60 years of the side effects that are going to occur as time goes on and the secondary problems that these people are going to have. And the city of New York is facing tremendous financial burden to take care of these people. So they're just saying, oh no, they don't have no poisoning. We did the wrong test. They actually did the right test, they just didn't want to, they didn't know how to interpret it. Actually, the Trade Center, the towers, there was a lot of mercury in those buildings, a lot of mercury. Most of your switches, okay, are mercury switches, your fluorescent lighting, the medical departments, you know, with their blood pressure cuffs and their thermometers and, you know, I mean, just those things. I mean, there's probably other sources of mercury that, you know, nobody's thought of yet, but yes, that building was full of mercury, and it all went up into the atmosphere. So I don't think if they've traced where that's gone over these last couple of years, I haven't seen any reports on it, other than real early on when they were detecting the higher mercury levels down in Florida, because Florida's very concerned their black panther is not reproducing because of mercury poisoning in the Everglades. So, you know, mercury is a big problem. Nobody wants to believe that it's amalgam, of course, so. Yeah, sure. It's only shipped to you as a biohazard. It's only carried away as a hazardous material, but while we're storing it in our mouth, it's perfectly okay. Yeah, makes sense to me. So, okay. DMPS and the metals it mobilizes. Andy Cutler mentioned that each chelator has a specific metal it likes to bind to. And that's true. They have greater affinities for some than for others. EDTA really likes to bind to calcium. That's why they thought that it was going to be the great boon to curing heart disease. It likes calcium, it likes lead. DMSA likes lead. DMPS has its highest affinity for mercury, whether it's organic or inorganic. It likes mercury. It will also pick up lead and arsenic. It will also bind to copper, but it will not bind to copper and pull out a lot of copper if there is not an excess of copper already there. It works by law of mass action. Whatever it likes to bind to, it's going to bind to whatever is in greatest quantity. So if you have a whole lot of copper and not much mercury, you're going to see more copper come out in the urine than mercury. By the way, copper does accumulate with mercury, and mercury will often trigger the formation of metallothioneins in the body, which are mercury traps. And when that happens, it can happen in the kidney. It can happen in different places in the body, but the kidney is one of the big ones. So when these metallothioneins trap these metals, it just sits there. And then you come along with a chelating drug, and it'll clean a lot of that out. So you see all this high copper level, maybe high zinc, because it will also trap zinc, and they will also trap mercury. So that's what DMPS does, is it works first on the kidney. Most of what you see on your first administration with DMPS orally is it's cleaning out the kidney. So whatever you see coming out in the urine, that's what was usually there in the kidney. Then it's by one, with each treatment, it goes through and it clears each organ and pushes everything toward the kidney to get it out. So you will see levels start to come down. You know, and initially on a challenge test, the initial challenge test, you may see a high number, or you may not. But that's reflected in what's coming from the kidney. Then as you progress on and do some additional treatments, you'll see your numbers rise and fall. And this is telling you really a story about how the metals are being mobilized and moved through the body. On page 7, it'll tell you in this little DMPS handout, it tells you which metals mercury or DMPS likes to bind to. Mercury, number 1, silver, cadmium, copper, lead, and zinc. Will also bind with manganese, molybdenum, thallium, tungsten. Excuse me. In Germany, DMPS is approved for both mercury and lead poisoning, but it's very frequently used for arsenic poisoning as well. In fact, there are 2 new textbooks, medical toxicology textbooks, coming out this year with protocols in them, chapters in there on arsenic poisoning, acute arsenic poisoning, and the use of DMPS. It gives a whole protocol for treating acute arsenic poisoning with DMPS. And the 2 different textbooks that are coming out, one is by Lippincott, but the author of those chapters is a Dr. Michael Kosnett, who is an MD toxicologist attached to the Rocky Mountain Poison Control Center. And he is also currently the president of the American College of Medical Toxicology. So he probably understands DMPS better than most of the doctors out there. The toxicology group of physicians and scientists understand this drug better than anyone, almost better than we do at Heil. Their preferences for DMPS over DMSA, and so you'll be seeing a lot more information come out, because DMPS has been in the past used as a preventive against radiation poisoning. It doesn't work as well after the radiation poisoning is there. Then you have to look at other drugs, but to help prevent the acute effects of radiation poisoning, DMPS has shown a lot of promise with that. Zinc DTPA, calcium DTPA, and Prussian blue. The DTPAs are used, intravenous medications, injectable, and Prussian blue is oral. Heil actually makes the only Prussian blue in the world that's approved for internal use. It's a pure pharmaceutical grade chemical. There are other companies who make Prussian blue, but it's used for dye. So anything blue that you see, it started out with Prussian blue, the color blue, in dyes, paint pigments, various colorings. They all started as Prussian blue.
The radiation is X radiation or fallout?
I'm sorry, the first radiation you said?
X-radiation, X-rays from chemotherapy versus fallout, both?
Both. Not as effective in the radiation fallout from like a nuclear blast as it would be lower doses, but yeah, it is effective. And in fact, there was a new chemo drug that was just approved by the FDA last year, and it's arsenic trioxide. So now the toxicologists are concerned that they're going to see a lot more acute arsenic poisoning. So DMPS is going to be the recommended treatment for that.
Are there any drugs for acute radiation
Well, for acute radiation poisoning, yes, it would be if they were like at ground zero, it's the zinc and calcium DTPA, followed by Prussian blue, and of course potassium iodide to protect the thyroid. Okay, I want to make sure I answer any questions that you have about the DMPS. I just wanted to cover a few key points about it, and how in using it, that oral is the preferred method of administration, and that it doesn't dissolve fillings, amalgam. It doesn't do a lot of things that has been touted to do. It can be a very effective medication, as well as very safe if it's used properly. And that's why Heil does put out the scientific monograph to show you all the different parameters and the different ways that doctors have used it, and in what dosage forms, what dosages and what treatment regimes. You can give it daily, you can give it weekly, you can give it monthly. Here it kind of got started as an IV, given once every 4 weeks at a 3 milligram per kilogram of body weight. Orally, you can use higher doses. You can go to a 5 or a 10 milligram per kilogram of body weight with no max out dose like you have with the IV. So for a big heavyset person, like a 300-pound strapping guy, you wouldn't want to give him the same dose that you would give to a 110-pound woman. So the toxicologists usually use it on either a straight 300 milligrams as a challenge dose, or they will dose it based on body weight, so that then you get the correct dose regardless of whether you're dealing with a child or with an adult. You're basing it on the body weight. All of that is mapped out in this little handout that I gave you, and also in the on the CD. Any other questions about DMPS? Yes, Dr. Klinger.
In Russia, DMPS is used also as a blood pressure drug.
Yes.
Do you know anything? Would you relate anything of that? I use it for that, and it's wonderful to lower somebody's blood pressure permanently, but nobody seems to be talking about it. So,
Well, yeah, it's actually listed as one of the side effects to the intravenous medication is that if it's given too rapidly, you do get a drop in blood pressure. But I'm not sure of its exact direct mechanism on what it would be doing for blood pressure, other than metal accumulating in the kidney will cause high blood pressure. So if you're chelating any metal out of the kidney, that would alleviate a blood pressure problem temporarily, and until the metal built back up. So there again, you're looking for exposures, but a lot of people do have accumulated metal, particularly older people. If they're over 50, over 60. We grew up with lead in our environment, a lot of lead here, leaded gasolines and that sort of thing. So you will generally find a lot of lead in the urine of those people after you give them DMPS, and if you can reduce that lead level, then you see their blood pressure come down. But it does have a cardiovascular effect, and that is what the first side effect and the warning on the DMPS given IV is if you give it too rapidly, it will drop the blood pressure very quickly. So I don't know how are you giving it IV to do that, or are you giving it to them orally? I am? Okay. Well, yeah, that would work. It would be a slower delivery. You wouldn't get the real sudden drop giving it IM. So, do you still do it based on body weight dose, or are you doing it? Okay.
so the question, but since we have you, I have one question, two questions. One is, do you see any meaningful other oral substances that we could give along with it, like methionine or acetylcysteine or other lipoic acid? Is there any synergistic effects or anything we need to be warned about, like any instrumental effects that
If you're talking about oral administration of those things, I don't really see any problem. However, with the IV, you do not want to mix the IV solution with anything else, and that has happened. It's being given as an IV drip, mixed in with vitamin C and other things. And Procaine probably wouldn't have a negative effect. I know that it was given that way a lot, but Procaine given IV can also have a cardiovascular effect and drop the blood pressure. So that would be the concern there, because DMPS will do that as well. But given that oral is the preferred route of administration, then you don't get the cardiovascular effect with the oral. And when you mix DMPS with anything, if you raise the pH of that solution to 7 or greater, it oxidizes if you've mixed it with anything. So like if you're mixing it with saline or something that's going to lift the pH to at least a 7, it's going to oxidize it, and we don't have any data on the ability of oxidized DMPS to chelate.
What is the pH basically?
When it's compounded to solution, it comes out at about between 4 and 5. Usually about 4.5 is the pH of the solution, and that's where it needs to stay. I mean, adjusting the pH is to make it more comfortable for the patient, and I understand that because it has such a low pH, it can be a painful injection. But if you oxidize it, it's still probably going to be a painful injection and isn't going to work as well. So that's why you don't want to mix it. You don't want to drip it, because the longer it's exposed to air, the potential for it to oxidize. So dithiols oxidize quite easily when exposed to air. So that's the other consideration for not giving it by the drip method, because it just takes so long. And I know there are physicians doing it, but we advise against it.
More questions. Like, one is before meals, after meals, at bedtime. Like, any preferences with that? That's my first question. The second one, often a day or two after DMPS shunt, people have this complete loss of short-term memory that seems to be completely reversible, but it lasts for 2 or 3 days. Some people have that. Do you know anything about that?
When giving oral DMPS, you want to give it on an empty stomach and keep them in VO for about 2 to 3 hours, because it goes down into the intestinal tract, and you get your peak excretion of metal at about the 2-hour mark. You don't want it to compete with anything else, for absorption. So you give that, keep them in PO for that couple of hours. Make sure they're very well hydrated. With the IV, make sure they're well hydrated. Eating is not an issue with giving the IV. It's probably better if they do eat, in case they're sensitive. They may get a drop in blood sugar, and then it's going to be hard to know if they're reacting to their low blood sugar or to the DMPS or to the metal you might have mobilized or any number of things. So I think eating would be just like they recommend for any other chelating treatment, IV chelating treatment. Always eat before you go, and drink a lot of water. They should not take any minerals, however, the day they're going to get DMPS. And there's a question from back here. On memory. Wow, gosh, maybe I didn't take any DMPS 2 days ago. So, I don't know. Have not run across that. Nobody's made that comment to me. But if it seems to be a temporary thing, of course, a lot of things will interfere temporarily with memory, I think. So if it's just temporary and you're seeing it doesn't last, I don't know. I can however, go back to the experts at Heil, Dr. Ruprecht, and see if he's heard anything about that or if he has any data on it. I don't. Yes, okay.
What would you recommend? You've been talking about doing baseline and then doing a challenge. How would you recommend doing challenge testing in view of the bad reactions that some patients have?
Well, if I were a physician, I wouldn't just do. I would do baseline testing, yes, but included in a workup, in addition to getting a good history on them, I would also be doing other tests, not just looking at urinary output or hair metal levels. I would also make sure they're not anemic. I would look at RBC mineral levels because of zinc deficiency. The symptoms of zinc deficiency can be exacerbated by DMPS. And I would get plasma amino acids, and I would look at their sulfur status. There is some data, it's not published, showing that supplemental methionine can enhance the effect of DMPS, but methionine also has the ability to chelate some of the metal out, and that may reduce any potential side effect with the DMPS. Sulfur is also antioxidant and anti-inflammatory, so and it helps with your vitamin mineral status. So I would look at certainly mineral status in those patients and sulfur protein status. Methionine, cysteine, cystathionine, glutathione, all of those protective components that are in the blood. And then think about giving them the DMPS. I think you should get them ready for chelation. Chelation is pretty dramatic on the body, has a pretty profound effect. And I think if people are anemic or they're mineral deficient or any of those things, those people have a very difficult time. They're usually the ones that get sick. They weren't prepared for it, for chelation. Because when you mobilize, when you give a chelating drug, you are literally inducing an acute poisoning. And that's how a lot of these people are going to react. They will act like they're acutely poisoned because they are acutely poisoned. Why would it be? No, it's not. If you suspect mercury, then DMPS has the greatest binding affinity for mercury. What I have seen in the cases that doctors have sent to me to look at is that people who got DMSA first, and then they tried to switch them over to DMPS, those were always the sickest people. I don't know what about the DMSA affects how the metal comes out or affects how DMPS is able to bind. But I've never, of the cases that I've seen, I've never seen a good outcome with that if they use DMSA first. Some where they use DMPS, and after they got the metal level in the urine down, way down, they'll say, okay, now I'm going to switch to DMSA as the cleanup agent. And I'm like, if it's cleaned up, it's cleaned up. You know, if you've gotten rid of the metal with DMPS, there's no scientific evidence to show that DMSA would benefit that patient. It's just an additional exposure to a drug that they probably don't need. And I think that habit came out of the rumor that DMSA will remove mercury from the brain. And it doesn't. So it's just giving the patient another drug. And if you get a little bit of a mercury spill, you may have gotten that anyway. Remember, we're actually a conduit. You know, where people get into trouble with metals, toxic metals, is that their excretory systems shut down. The mercury particularly goes in and it shuts down enzyme systems and shuts down a lot of biochemical reactions. This is why people get sick. So the focus should be first to get those systems open and working again by giving them biological support. And a lot of times on their own, they'll start to spontaneously excrete heavy metals. Sometimes they don't need a chelating drug at all. So, but you don't know that unless you do all of the proper laboratory tests and look at all the parameters. You know, so what I tell doctors is, don't focus on the metal, focus on the person. How can you best biologically support this individual? And see how far you can get with that before you give them a chelating drug. Now it sells less DMPS for me, okay, for the Heil company, but that's the proper way to do it. That would be, you know, the only time you want to rush right in with chelators is if you have an acutely poisoned person in an industrial accident situation. If you don't give them a drug right now, they're dead in a matter of hours. And it's happened. We've been involved with some of those cases, but then you don't have time. You just have to give them that drug and that's it. But those people usually aren't poisoned. They're not what you call fragile. You know, it's these chronic, ongoing, low-level exposures over years that these people get all these other biochemical aberrations. Okay, well, I'll take you first. I'll say you first, and then you.
Ascorbic acid is the same income as water is acidic, but use it with DMPS as a script, and it makes it 2 pH, that's acidic. You're saying that DMPS should stay at about what level of acidity? 3 or 4?
A pH of about 4. When it's compounded and put into solution, it comes out generally in the range somewhere between 3 to 5 really. So ideally it's usually about 4.4. When they make it in Germany and put it in the ampules, it tests out of a pH about 4.5. So. No, what I'm saying is when you put it in an IV solution, the concern is we don't know what interaction there is between ascorbic acid and DMPS. We don't know if there's a drug interaction there that's occurring, in the bag. Nobody's looked at that. The concern is usually with vitamin C IVs, sodium bicarbonate is added to that solution to buffer it, to get the pH up, because when the pH is low, it's a painful IV, and people tend to complain when it hurts, if you're getting an IV. So they'll put the sodium bicarb or a little magnesium or, saline, a little saline or something like that to buffer it up. That's where you get into the problem. It's that the sodium solutions are going to increase the pH. That's what makes it more comfortable for the patient, and that would then oxidize the DMPS. 7.2.
So if you IV push into
Well, you mean when you, okay, are you talking about an IV solution? An IV push just straight with the DMPS? Yes. And then the DMPS, once it goes in, with it being a 4.5 and blood being 7.2, it does change the pH of the DMPS, and it oxidizes, but usually after it binds to something. So you do get some oxidation of the DMPS, okay? But you don't want it to oxidize, you don't want it oxidized before it goes in, okay? If it does happen afterward to some degree, but they know that. But DMPS, it does not get metabolized into anything else either. It stays, it goes in DMPS, comes out DMPS, bound to a metal ion. Okay.
Do you have any guidelines
When to stop the drug?
And given that we live in an industrial society,
Well, chelators are used for very specific, purposes for specific periods of time, given an individual situation. I would hate to think that we're already to the point that we all are faced with having to take a chelating drug periodically for the rest of our life. That's pretty scary, even though we live on a very toxic planet. I think that once you see the metal levels and reduced in the urine, okay, down to whatever your laboratory markers are, less than 3 or less than 5 or so many grams per creatinine, different labs have different ranges, then that's a pretty good indication. But there, I think that's when you really need to support these people with a lot of nutrients, because that's usually why toxic people got toxic to begin with, is their nutrient status had just deteriorated to the point that these metals were allowed to accumulate. We should be conduits. Goes in, comes out, goes in, comes out. It's when it goes in and doesn't come out that they get into trouble. So how do you turn on the excretory system and get that so that it continues to mobilize and make you a conduit once again? That really should be the goal, because our planet isn't getting any less toxic, unfortunately. But I don't know that we can put everybody on these chelating drugs forever either, because long term they'll have effects. I'm sorry, I couldn't hear you.
talking about occupational exposure,
Mm-hmm. Yes, well, there's still, that's true, occupational exposure. You're always going to have that risk, which is why you should institute all the precautions using the respirators that filter out the mercury vapor, and usually all the chairside people wear those or should wear those. And here again, attending to your own health and looking at your own biochemistry. What are the normal constituents? Are your mineral levels adequate? Are your amino acid levels adequate? Those kind of things go a long way to protecting you. Using sulfurs, a lot of sulfur foods in your diet, which will help to protect you from the free radical effect that metals have, and from the oxidizing effect. So I think a good nutritional approach and doing some testing once a year, there are laboratories that offer like packages of this and that, you can get metals and amino acids and minerals done, and checking that periodically, because yes, as a dentist and your staff, you do have concerns, ongoing concerns, but I don't know that taking a drug every year or a course of drugs every year is really the answer. It doesn't hurt. You can check it once a year and see if you're accumulating any metal. Do a challenge test maybe once or twice a year, but I don't know that I would go so far, if I were a physician, to say you're a dentist, you need to be taking this drug all the time, forever, do this for the rest of your life. I don't think that's really an appropriate way to go.
I've heard it's claimed that doing challenge tests on most people's populations are very asymptomatic.
Mm-hmm.
Will show that they're toxic.
Well, it's true when you give someone a challenge test, give them a chelating drug and do a challenge test, in a lot of people you will see that post number go up. Does that mean that person is toxic? The number alone does not tell you that. I know a physician, that puts out a mercury level of 1,000 micrograms a day in a 24-hour period. Not one symptom. None. Is he toxic? Doesn't seem to be having an effect. I think he had and this happened shortly after he painted his kitchen with the old paint that probably still had mercury in it as a preservative or as an antifungal. He has no symptoms, none whatsoever. So just because the number is high doesn't mean the person is toxic. They may be able to handle it. It's their antioxidant status. It's all those things. What is their diet? That sometimes they're just acting as a conduit. Just because you find a high number doesn't mean you necessarily want to treat them. You know, what else is going on with them? Look at your other biochemical parameters. Do they have an elevated cholesterol, which would be an indication of, you know, their antioxidant status is low, something's irritating them, you know, their cholesterol's going up? Then maybe, yeah, there's clues. You've got to look for other clues. The numbers by themselves on any given test do not mean anything. You cannot make a diagnosis based on one laboratory report or one kind of test even done several times. If the history isn't there, if the symptoms aren't there, if the other biochemical parameters aren't there, all you have is somebody that's acting as a conduit, which is what we're supposed to be doing anyway. Any other questions?
I stepped out of it. You said that the DMPS doesn't dissolve amalgam. So are you saying that giving the DMPS, you're not going to collect mercury out of the amalgam? Is that what you're saying?
That's right. It will not go in and pull the mercury out of the amalgam and dissolve your amalgams. Now, it's just like pregnancy does not dissolve your amalgam. I mean, but, you know, in pregnancy, the baby, the fetus, is taking all the nutrients. And we used to see a lot of problems. Women, their dental status did deteriorate dramatically before the routine use of vitamin and mineral supplementation during pregnancy. So the same thing, you know, when you have heavy metals present and you give DMPS and you're mobilizing those toxic metals, it's going to displace some of your trace minerals, and you do get a deteriorating status, and the dental situation is included in that. So if you don't have enough of the normal biochemistry there to support health, your dental health, bone health, then you may see a deterioration of the dental status. But that's not because the DMPS ate your fillings. Does that answer your question? If it doesn't, tell me. I'll go back and see if I can. That's right, and I would agree with that. And the reason why I agree with that, and the reason why, and you can ask him, it makes no sense to try to use an antidote to cure somebody or help somebody when you don't remove the exposure. The first law of toxicology is remove the patient from exposure. In the case of amalgam, it's remove the exposure from the patient. You can't simultaneously feed a fire and fight a fire. You know, so you have to get them away from the exposure. If the amalgam is their greatest source of exposure, then that's what you need to get them away from, or get it away from them.
Pam, let me say something to that. Some of you have worked with me on the DMPS issue, and the German literature is pretty clear that they've done large studies with large groups, cohorts of patients, and double-blinded, and there was no problem with it. What we have here in the US is a lot of opinion based on hearsay. And yes, when you start using DMPS on people, there's a lot of emotional material coming up, a lot of other stuff that then gets interpreted as being an adverse effect from the drug. Every time we checked in my office, I've been using it for 30 years now, is when there's a reaction. Most of the time, there's a link in the brain between the metals and the emotions. There's a close neighborhood. When you mess with one, you mess with the other. And that has been largely ignored here and overlooked, and people like me and others that have been trying to get the attention to this have been sort of sidelined. And yet, you know, you have to be careful that
some of the opinions that are given here and on the internet are opinions by people that have forgotten to look that there's actually large studies, and the whole rest of the world has been using this drug for 30 years now, or 35 years, very, very safely. And in fact, the studies that are quoted in the early work of Downrower, there was some very good lethal doses studies done and side effect studies, and it is on a molecule by molecule basis far safer than aspirin. You know, that gives you a little bit of an idea of how dangerous it is. And so, but unfortunately there is a field now, a mental field in this country that is scared of it, and you have to account for it because people that you treat are in the field, and they're going to exhibit some of the nocebo effect that has been created by people, some of it intentionally for political reasons. And it is a real force to reckon with now.
That's true. A lot of times, even Andrew Culler pointed that out, is you give somebody the drug and they get some sort of change, and so they immediately blame the drug. It's just a natural thing that humans want to do. I did X and Y happened, therefore Y is caused by X. That isn't necessarily true. You have to remember, when you give a drug, I don't care what the drug is, whether it's aspirin or whether it's an antibiotic or whether it's a painkiller or a chelating drug, you are creating a shift in the body. Okay, so the drug may create a shift or help the body create a shift, but it's not necessarily a direct relationship between the drug and what you're seeing. The acute poisoning situation, yes, chelators can cause acute poisoning. Why? Not that you've put the metal into them, it's because you've drawn the metal or coaxed it from tissue spaces, from intracellular to extracellular space. The body doesn't let heavy metals or other toxins stay circulating in the blood for very long. This is part of our self-defense mechanism. It wants to be rid of it. If it can't get rid of it via the normal excretory routes, through the bile, through the feces, through the urine, then it's going to put it someplace where it can do the least amount of damage. Okay? And it just keeps storing those things there and storing them and building them up. When you come in with a drug, and that's the downside, is we have no test that will tell us exactly how much metal is stored in a person's body.
We do. It's called autonomic response testing, and it's very, very close to the truth.
Okay. All right. I will agree with that. There's no measurable, body fluid we can get out that says you have this much in your urine, therefore you have this much in your body. So that's what makes it very difficult. So when you give a medication or a chelating drug, you don't know how much metal you've mobilized, that it could kick up and cause, symptoms of an acute poisoning. How much metal has to be mobilized to cause these acute symptoms? Who knows? That varies from one person to the next. No two people react the same to the same stimulus. So they don't react the same to the metal. Some people can have a lot of metal, be fine. Other people, they even think about metal and they're sick. So it's very individual, and this is the hardest thing, I think, for practitioners and physicians to learn or to understand. Is this is where the art of medicine comes in. It's being able to recognize when the patient is really sick, even though they didn't have as much exposure as another patient sitting next to them. Mm-hmm.
Would you recommend oral DMPS prior removal of amalgams as a scavenger? We've been doing it in our office for a long time.
Well, you asked me if I would recommend it. No, I probably wouldn't. Well, here again, and I don't have enough information from that one statement. What have you done to support the biological processes in the body, or are you just giving them a drug trying to get the metal, trying to grab whatever's there?
Biochemist physician in our practice, you're
Mm-hmm.
able to do it. The biochemist engineer and the physician,
Mm-hmm.
we've been doing it, use it as a scavenger.
And are you, oral? Did you say oral? And
Because when you're removing, you have a lot of garbage, right? So,
mm-hmm.
as a precautionary method, we recommend it, we've been following that.
And so if it's their first dose of DMPS, and earlier I stated that the first dose of DMPS actually clears the kidney or binds to a lot of the metal in the kidney, how can it act as a scavenger or cleanup for what they're...
When you remove an amalgam, no matter how much application you
Mhm.
do, the mercury is flying everywhere through the saliva, etc.
Are you giving it before, during, or after? Before. Okay.
Just before we start.
Okay. Because the half-life of DMPS is about 1 hour. Peak excretion is at 2, so if you work on it much longer than that, I can't see that it would have much of a beneficial effect. Might be better to wait until after if you're going to do that. Until after, you know, when you're finished with them and you're finished with the procedures. But there are a lot of things that physicians and dentists are doing. You know, I can only tell you what Heil's position is. That's why they don't have a protocol, because there's too many variables from one person to the next, from one kind of practice to the next, from one kind of profession to the next. I see and hear a lot of things. There's nothing right and there's nothing wrong. You have to feel out what works for you and what works for your practice and your patients. Okay. The one thing I want to comment on is on the informed consent. I gave you a guide for informed consent. If you are going to use DMPS, please write an informed consent and have your patient sign it. If you are going to use any drug that is not FDA approved, you need to be giving those patients an informed consent form. If you're going to use DMSA on adults for something other than lead, you need an informed consent. An informed consent is a culmination, it's something in writing that you and the patient have discussed so that they understand what it is you're doing and what the drug or the treatment does or is intended to do, and that you're not making any promises to them, and that you are telling them this is not approved by the Food and Drug Administration. This is where a lot of the stories on the DMPS backfire site, that's the issue they deal with. I wasn't told. I wasn't told this was an experimental drug. I wasn't told this wasn't FDA approved. My doctor gave it to me. I assumed it was safe. And if they had been told it wasn't FDA approved, they were given the opportunity to go and do their own research before they took it, it would have kept most of the doctors that I've talked to out of trouble. Learn about informed consent. The FDA does have guidelines on what should go into an informed consent, and they have very specific guidelines on what should not be in an informed consent. And I've tried to lay that out for you in this one little piece of paper. You can go to the FDA's website and look that information up. And there are legal firms who can help you put together a really good informed consent. The idea is to inform your patients. You want them to know. And full disclosure and informed consent, that's what protects your license more than anything. I don't care how good a doctor you are. You've got to always be straight with patients and put it in writing and give them a copy of the signed informed consent so that they know. Because I talk to a lot of people and I'll say, did your doctor have you sign an informed consent when they gave you the DMPS? No. What's an informed consent? I said, are you sure you didn't sign a piece of paper that told you what the possible side effects were? Why your doctor wanted to use this? No. That's what will get you in trouble faster than anything else I know of when you're using non-FDA approved substances or an off-label use of an FDA approved drug. If you have any questions about that, I'll be around all weekend. And thank you for having me. I enjoyed it. Hope I didn't put too many of you to sleep. I know it's after lunch. And if you want to get in touch with me, my phone number, my email, and our website is listed in this literature. And just remember, do not administer DMPS by the drip method like the book says. I made you fix that in there. Okay? Thank you.
Thanks, Pam. She's a nice, cool lady, isn't she? Oh, it's nice to let's have our break, and I remind you, please try to be back on time. I know, I know this is a hard one, but honestly, like, it's so nice when we all together know when we're going to be here and when we're not going to be here. Then we can get in a rhythm with it all. So see if you can do that. 4 o'clock.
They asked some pretty good questions too. Practical problem solving.
Yes, and that was really what I'd rather address than just giving them a lot of slides and science, you know. Go ahead.
That was a good lecture.
Well, thank you.
Didn't put me to sleep at all.
Oh, good.